Dr. Linda Bradley, founder and chairwoman of Cleveland Clinic Celebrate Sisterhood. Welcome to our 2021 virtual education series, Celebrate Sisterhood 3.0. During this series, our experts will share information to keep you and your family healthy. This program is designed especially for you. So sit back, relax, and enjoy. Hello everyone, I'm Dr. Linda Bradley, founder and chairwoman of Celebrate Sisterhood, Cleveland Clinic Celebrate Sisterhood. Welcome to this month's edition of Celebrate Sisterhood 3.0. This is a community outreach and education program that empowers multicultural women to embrace self-care and strive for optimal health for themselves, their families, and their communities. This event is pre-recorded. If you have any questions about the information shared today, please email celebrate-sisterhood@ccf.org. We have a great group of experts here with us today. Our guest physicians are Dr. Rosanne, head of medical gynecology and minimally invasive gynecologic surgery and program director of the minimally invasive gynecologic surgery fellowship at Cleveland Clinic. Dr. Cara, director of Benign Gynecologic Surgery and associate program director of the minimally invasive gynecologic surgery fellowship at Cleveland Clinic, and Dr. Eunice, staff physician in the Department of Vascular and Interventional Radiology at Cleveland Clinic. We also have two engaging patient advocates joining us today. Soteria Venable, founder and CEO of the Fibroid Foundation, and Tanika Gray Valborn, founder and chief patient advocate of the White Dress Project. Welcome everyone, and thanks for joining us. Today's topic is living your best life with fibroids and endometriosis. 60 to 80% of women are impacted by uterine fibroids, and 10 to 15% of women are diagnosed with endometriosis. We are so fortunate that we have many options for the treatment of these common conditions. There are newer minimally invasive surgical techniques that permit shorter hospitalization, shorter hospital stays, much quicker recovery. We will learn about new medications that can be prescribed by your physician or healthcare provider. No longer do women have to suffer in silence. First, we're going to speak with Dr. King about the symptoms, diagnosis, and treatment options for endometriosis. So, Dr. King, let's talk a little bit about endometriosis. You are a world expert. Tell me about the symptoms, how we make a diagnosis, and maybe even some of the newer treatment options, both medically and surgically.
Thank you so much for the invitation, Dr. Bradley. And you're exactly right. Endometriosis is a really unique and quite complex disease. So endometriosis is when tissue similar to the lining of the uterus can implant anywhere outside the uterus. And it can be in the pelvis, it can be outside the pelvis, so bowel, bladder, appendix, liver, diaphragm, it can really plant anywhere. And the longer that it's there, and the longer that it's there undiagnosed, it can start pulling in a lot of other symptoms for patients. And so I would say the initial symptoms that many patients present with are pain symptoms. So painful periods, painful urination, painful bowel movements, painful intercourse. But the longer that the disease is there, the disease itself can progress, but it can also bring in other organ systems. So things I'm thinking about are the pelvic floor can start spasming, the nerves can change and cause something called central sensitization, and it also can cause really drastic mood impact as well. And so when I see somebody with endometriosis, it's really important to take all of these different things to keep them all in mind when we create the care plan. In regard to diagnosis, unfortunately, there's not a clear, non-invasive way to diagnose endometriosis. And so the patient's history is paramount. Physical exam is also exquisitely important. And then we also incorporate imaging. And so oftentimes we start with things like a transvaginal ultrasound. Ultrasounds are really fantastic at identifying cysts that are on the ovaries. And so sometimes there's specific cysts called endometriomas that can be, that are from endometriosis. And when we see these cysts, there's a very, very high chance that there's other areas of endometriosis in the pelvis, which is when physical exam really comes in to see if we feel any other deeply infiltrating nodules. And sometimes we'll also order an MRI, which can additionally help us map out different endometriosis nodules that are in the pelvis.
Excellent. About what age do women present? And is there any ethnic variability in presentation, age of presentation?
Great question. And so endometriosis is an estrogen dominant disease. So we oftentimes see this disease in patients within the reproductive age group. With that being said, large nodules of endometriosis can actually feed themselves in regard to estrogen. So sometimes postmenopausal women can have endometriosis. Oftentimes it's suppressed because the ovaries are no longer functioning, but not always. And so a really common scenario that we oftentimes see are patients who have been on some type of birth control for reproductive planning. Then they'll get off their birth control to sometimes think about having a pregnancy. And when they're off that suppression, periods become much worse. And that's when pain symptoms really start surfacing. So oftentimes within the reproductive age.
Excellent. So who do you take to surgery and who do you offer medical therapy to?
So I will say that every single endometriosis patient that I have is very unique in regard to the treatment plan that we create. And really what dictates that is the pain symptom. So what type of quality of life does the patient have in regard to pain symptoms, and what are their fertility goals? Because a lot of the medical suppression or the medical options that we have suppress ovulation, it suppresses pregnancy. And so if a goal for the patient is pregnancy, then medical options aren't an option for them, unfortunately. So if a patient has pain and is planning on pregnancy, we oftentimes move to surgical intervention sooner because the medical options are not conducive with their fertility plans. In addition, if we see a large nodule on imaging, then that may move us to surgery sooner as well.
Now, we talk a lot about minimally invasive surgery or minimally invasive gynecologists who might be those who should be doing the surgery. Tell us what we do at the Cleveland Clinic as our care path team and our collaborative team when you need surgery. How does that work?
So the Cleveland Clinic has an amazing chronic pelvic pain and endometriosis center where we recruit physicians from all different subspecialties to really help the patient move through the entire journey of the pain process and surgery process. So with endometriosis, it's absolutely crucial to have a multidisciplinary team. And that includes your minimally invasive GYN surgeon. It can also include colorectal team, urology, pelvic floor physical therapy, REI, functional medicine, the whole entire gamut of providers that can really help the patient through this entire journey. And so I think the Cleveland Clinic is really unique in that we have all that team already built into our center. And so it makes it really easy for our patient to have all those different silos broken down and really make amazing progress towards improvement.
So is it true that you're now offering more robotic surgery for treatment and laparoscopic surgery instead of the large incisions? And I heard that even some of your patients go home the same day, several hours after surgery. Is that true?
Oh my goodness, you are so dead on. Yes. So minimally invasive surgery has been a complete game changer in the way that we treat endometriosis. So with most benign disease, which endometriosis is quote unquote benign, meaning not cancerous, what that means is that we typically can treat these patients with small incisions. So sometimes that's with conventional straight stick laparoscopy. Sometimes we do use a robot. It's all surgeon preference, but as long as we stay minimally invasive, then we get the same benefits of that type of surgery, meaning same day discharge for most of our patients. So we do our surgery, maybe an hour or two in the recovery unit, and then you can go home and sleep in your own bed. It's great.
Excellent. And I love it that you guys are also now using sometimes the newer medical therapies that have just been approved within the last year. So I understand you're a heavy user of that.
So with medications, yeah, it's definitely part of our treatment plan. And again, the patient's priorities really help dictate that. The newer medications that are out for endometriosis are still hormonally based, but they're now available in pill form when before they were only used in injection form. So for the right patient, it's really great to have that in our toolbox. And again, present all the options to the patient so they can choose the best fit for them.
Well, thank you so much for this information. And we're going to move on and learn a little bit more about fibroids.
Thanks.
Now, I'd like to thank Dr. King for some of this insight, but I would like at this time to just go to you, Dr. Coe. And I'd like to ask you, do you have anything extra that you'd like to contribute with your years of experience about endometriosis as a topic?
So first and foremost, thank you so much, Dr. Bradley, for having me join this wonderful panel of experts and also strong patient advocates we so need it in the community. So what I would like to add on to Dr. King's statements is to make the patients aware that they are in charge. We truly need to empower our patients. They are the ones to direct us clinicians as to what should be done. Just because endometriosis was seen during surgery or was suspected during an imaging does not mean that something needs to be done. It doesn't need to be taken out or cut out. It does not mean that the hysterectomy is the only solution for this patient. The patient needs to tell us whether or not she's bothered by pain, by the need to have pregnancies, and in so understanding, we would then approach the patient through a multidisciplinary approach. Part of being a surgeon is to know when not to operate. It's just as important for us to know what are the other options for the patients in terms of nothing or medical management or indeed surgeries. And when surgery is then to be approached, what is the correct procedure? If the patient is truly interested in a pregnancy, then perhaps we should do very little. It's endometriosis. Even though it behaves like a cancer, it's not a cancer. If the patient wants to preserve ovarian function, then we should perhaps just drain the endometrioma or the endometriosis contained within a cyst and do as little harm as possible so that we can move the patient on to achieve a pregnancy. Never let the physician tell you that your only solution is a hysterectomy.
Great. You know, we're getting smarter about endometriosis. Is this a disease just of women in their 30s and 40s? We have many of our participants or viewers today who may have teens, college-age students. What do we know about the life cycle, so to speak, of endometriosis? When might it start and when might it end?
Yeah, this is one of the very sad things about endometriosis is the delay in diagnosis. The studies would show that by the time the patients present with their symptoms of pain or abnormal bleeding, severe cramping at the time of their periods, or even in between their periods, that by the time they are diagnosed, there's a delay of between 7 to 9 years. Women have to suffer for that long period of time. We are advancing more and more in the use of imaging, non-surgical methods in terms of diagnosing women with endometriosis. And I truly believe at a center such as ours, Linda, where we have a center of excellence for endometriosis, and we've been able to bring in our radiology partners and experts, we're able to diagnose endometriosis at a much earlier time without requiring a surgery.
Well, Dr. King has given us some information about medical management, so I won't ask you that. But you know, July is Fibroid Awareness Month. And let's turn our attention now, Dr. Coe, to what exactly are fibroids. And then I'll turn some things over to Dr. Moon and then our two excellent patients advocates in just a moment. So what are fibroids? How do you establish a diagnosis?
So fibroids are actually very common, as you said. Between 60 to 80% of all women have fibroids. Most women with fibroids don't even know they have fibroids. And again, just because someone tells you, we saw that there are fibroids in your uterus, that's seen on ultrasound or any other imaging, does not mean that something needs to be done. Fibroids are abnormal, or they're tumors of the muscles of the uterus that is usually benign, meaning it's not cancerous. And it's only requiring intervention if it presents with abnormal bleeding, bleeding in between your periods, or heavy bleeding, or difficulty in achieving a pregnancy or maintaining a pregnancy, where something then should be done.
So how do you establish the diagnosis? What kind of imaging test? What do you do? What does a patient need to have as she leaves your office or another physician's office to really establish that diagnosis?
So the most common way to establish the finding of fibroids is with pelvic ultrasound. So it's with the use of a probe that is done both abdominally and also transvaginally for us to be able to diagnose this. There are certain situations where we may not be as clear as to the location of these fibroids that we may require further imaging, such as with an MRI or with an hysteroscopy, that is with the use of a scope that is placed through the cervix to look at the lining itself to see whether or not fibroids are within the cavity.
You know, with so many women having fibroids, and we know that by the age of 60 in America, 1 out of 3 women has had a hysterectomy, which means removal of the uterus, no chance for children, no more menstrual cycles, and for some it is a perfect answer. But we know that 90% of hysterectomies are for non-cancerous conditions and often due to endometriosis, fibroids, and then that other condition that mimics fibroids, the adenomyosis. So how do you, Dr. Coe, as a world-renowned surgeon, gifted hands, determine if surgery should be the first option? And if so, when is it used and why?
So having said that, Dr. Bradley, hysterectomy to me is never the first option unless there's a cancer involved. So we as clinicians need to make sure that cancer is not in the picture here or not in the mix. When we've ensured that it's not in the mix because we've obtained proper evaluation preoperatively, such as with a pap smear or with the endometrial biopsy, or if imaging comes back to us looking like this is reassuring, then we look at all of the other options first to determine the best treatment approach. And I often list it down for the patient, starting with medical management to non-hysterectomy options. And this is where Dr. Eunice Moon would come in with her treatment modality. We also now have advanced radiofrequency with the use of MRI guided or with actual direction of the radiofrequency with ultrasound guidance. These modalities are now available. We also have just the removal of the fibroids themselves, and that can be done through different routes. And then the very last option on my list for the patient is that of a hysterectomy, which is the removal of the uterus itself.
You know, we've moved from large surgeries that go from stem to stern, but we are now talking about surgery that's considered minimally invasive. You lead one of the best fellowships in teaching young doctors about what we used to call keyhole surgery, small incisions, several of them in the abdomen, in order to treat many of the conditions we're talking about today, fibroids and endometriosis. So when we talk to our patients and when I make a referral to MIGS, minimally invasive gynecology, what is it exactly? Are all doctors MIGS doctors? And what are the benefits of minimally invasive surgery?
We like to hope that all physicians or surgeons that we train out of our residency programs would be MIGS surgeons. But sometimes there are very complex procedures that require additional training. So through the AAGL, which is a society, we have come up with multiple fellowship training programs throughout the country and the world. And these are 2-year fellowship programs where our learners are then exposed to multiple difficult, advanced, complex cases. So minimally invasive GYN surgery would then allow the patient to have the least amount of incisions, sometimes no incisions at all on the abdomen. These procedures can be done transvaginally as well or transcervically, allowing women then to recover much faster. These procedures often can allow patients to go home the same day. and they would recover much faster. There's less blood loss and also less complications.
Yeah, we're also seeing, as you know, less pain medications. Cesarean sections and hysterectomies are often the most common surgeries done for women. And in this era, unfortunately, of drug use and becoming dependent upon opioids that sometimes stimulated from being given from a surgery, these surgical procedure, I've seen your patients and my patients sometimes just going home on higher doses of Motrin or Motrin-like products, and like you said, back to work and activity in a very short period of time. So would you say that if someone is seeing a physician somewhere else, that they should ask about a minimally invasive approach to their surgical problem?
Absolutely. I'm a strong advocate for asking for a minimally invasive procedure, but also to empower our patients to ask for a second opinion, right? How would someone else approach this procedure? It's a huge decision to put yourself under somebody else's hands for any surgery. A second opinion should be part of the armamentarium.
And one more question before we go to Dr. Moon in a moment. Myomectomy, that means keeping the uterus, but removing all of the fibroids, or as many of the fibroids as possible. Can you tell us a little bit about the history of myomectomy, how we do it nowadays, and its benefits compared to the 1840s when women, again, had hip-to-hip surgery with big incisions in the hospital 4 to 6 days. What are we doing now, and what exactly is a myomectomy?
Right. Myomectomy is where we remove the fibroids, and it can be done in multiple ways. So Dr. Bradley alluded to a time when all women would have to have a large incision, whether it's hip to hip or from pubic bone up to the umbilicus, maybe sometimes even up above the belly button. So now we can do it in minimally invasive approaches. Dr. Bradley here is one of the world's pioneer and experts in operative hysteroscopy, which would then require the removal of these fibroids through the cervix with her instruments. She has done the most difficult, most complex cases that I no longer even do these procedures because we've got the best right in our very backyard, so to speak. So there's the hysteroscopic approach. There is the laparoscopic approach, which are keyhole, small trocar incisions on the abdomen. It can also be done with robotic assistance. So if someone, a surgeon, is well-versed with the robotic approach, it can be done that way. But we've also done it through very small incisions, one through either the belly button or even through the phalansteal, which is where the C-section scar can be made. Sometimes we're able to access these large fibroids through these small incisions. Very rarely do we really need to go with a huge abdominal incision.
Yeah, your techniques, and I've happened to watch you between surgery and our team at the Cleveland Clinic, phenomenal. The types of work that they can do with very small incision. They're skilled. They provide excellent outcome, and I'm so glad that we work together and do what we each do best. So again, thank you so much. And what I want to also do is we're going to pivot for just a moment because sometimes patients need no general anesthesia. We can look at fibroid treatment with our interventional radiologists. And I personally have been working with Dr. Moon a long time, really since the early 90s. And I would like her, she's an interventional radiologist as we've described, but tell us exactly what is uterine artery embolization and why would someone maybe want to consider that? Walk us through the procedure a little bit.
Hi, Linda. Thank you for having me. Let's see, uterine artery embolization, or nowadays we call it uterine fibroid embolization, is a minimally invasive procedure, and it's done in radiology. And most people don't really see radiologists as interventionalists or surgeons, but essentially that's what we do. Fibroids, as you guys know, are benign tumors of the uterine muscle. It's got heavy blood flow and lots of blood vessels that go to it. how we treat the fibroid is we go in and take away the blood flow to the masses in the uterus, essentially starving the fibroids. So as far as how we do it, we like to meet with you beforehand in an outpatient consultation setting. You know, it's pretty chill and relaxed, and we go over everything. We talk about everything, go over the procedure in detail. We review any kind of imaging of the fibroid you might have, whether it's an ultrasound or an MRI. We may order additional imaging if we think the MRI would be helpful for us to make the decision about, you know, whether you'd be a good candidate or not. And then we try to answer all of the questions related to the procedure and the recovery as well. And then after we go through all this and we determine that you are a good candidate for the procedure, so we bring you in on the day of the procedure, you know, about an hour before, you know, we get you changed, put an IV, and then we bring you into our procedure room, which is sort of looks like a surgical suite. So we do the procedure under what we call moderate sedation. So that means that you're a little bit sleepy, that you're very relaxed, and you kind of don't care what happens. And so under sedation and some numbing medicine, we make a tiny little nick in the skin, whether it's through the wrist or in through the groin area. We put a skinny little tubing called a catheter into the artery that feeds the fibroids. And we do this under live ultrasound and live X-ray guidance. So once we get our catheter in the correct location, what we do is we inject these tiny little medical beads, and we inject them into the artery that feeds the fibroid, and we block the blood flow. And the particles can't go anywhere else other than the uterine artery. That's a common question that people ask. And it can't move elsewhere once it's placed into where we need to go. The procedure takes about an hour or so, sometimes a little less, sometimes a little more, depending on how much work we have to do. And then we keep the patients overnight at the hospital to help manage something we call post-embolization syndrome. And that's, you know, when the fibroids, you know, start to die, they start complaining about it, and there's, you know, some soreness and some fatigue and nausea that goes along with it. You're discharged home the next day, and you're able to return to work in 10 to 14 days. Now, this procedure, while it's a very, you know, short procedure, overnight stay at the hospital, very easy-ish, but it does take the time for the body to shrink the fibroids after the procedure. So unlike a surgical procedure like a hysterectomy or a myomectomy, you know, you have to give it time for the body to shrink the fibroids and resorb the fibroids. And it takes about 3 months for most patients to see a real benefit.
And what symptoms, I'm going to speak with our patient advocates in a moment and hear their stories, but with embolization, if you had to have the ideal patient with the textbook ideal symptoms, because not all symptoms are treated with embolization, what would you say the symptoms that respond the best to uterine artery or uterine fibroid embolization?
Well, I would say that most patients are pretty good candidates for the procedure, but, you know, very few people are what we consider the ideal candidate. The ideal candidate, if I had to create a patient, you know, for the procedure, is a woman who is, let's say, done with her family planning, has had one or more symptomatic fibroids, so you have to have symptoms. And then we want the fibroids to have good blood flow to it and what we call good enhancements on the imaging. But then we also have patients who are better managed with fibroid embolization because they're not good surgical candidates for one reason or another. And those patients maybe potentially have multiple pelvic surgeries in the past with lots of adhesions, or they're very, very sick, for whom anesthesia is a significant risk, or patients who are on chronic blood thinners for blood clots or something else in the past. Or maybe, you know, because the patient has a very difficult body habitus. So the surgery and the risk of the surgery is much greater. And in those patients, yes, they may not fit the bill of the ideal patient, but for them, embolization may be less dangerous or less risky of the options that they may have.
Right, and I also agree, because as you know, I've referred many patients to you with these complex, what we call comorbidities, the hypertension, the being overweight, multiple surgeries that you've mentioned. And if a patient does have the treatment with embolization, uterine artery embolization, and doesn't get enough relief of her symptoms, surgery can still be an option. So I do want our viewers to know that. And sometimes a non-surgical approach like Dr. Moon and her team offers is really safest and the best. And again, I do think a gynecologist or healthcare provider should make our patients aware of all of that. And who is a part of our team, who do we collaborate with? Because here at the Cleveland Clinic, we always say we're family, and so we work together to get the best outcome, hopefully with the best doctor for that problem. So I like what you just said. I think it's extremely telling, and I agree with you. What about the outcomes from uterine artery embolization, including pregnancy outcomes? If you could just briefly say something about that.
Sure. I think when we talk about outcomes, and I think it really depends on patient age, for one, how old they are, what kind of symptoms they're having, and what's our goal in treating this patient. If we look at the literature, patients who present with, heavy bleeding, they tend to be superb candidates for fibroid embolization, with probably over 90% of them having significant improvement within the first year. The patients who present with bulk-related symptoms, like having to urinate often, or having to wake up multiple times in the middle of the night to urinate, those patients do well, but they're probably not quite as successful, maybe in the 75% range of success. I think if the patient is in their mid to late upper 40s in age, the outcome is excellent. We have many of those patients making it to menopause without needing further treatment, because we're looking at treating them, maybe 5, 6, getting them through that hump. I see patients in their late 40s. And while their, indications may not be quite as, I need a harder, more definitive indications for somebody in their late 30s than I do patients in their late 40s, because all I need to do is get them through a couple years until their whole body, their own body sort of heals the fibroids, and they go into menopause, and the fibroids will most of the time shrink on their own. And so, we have, some data about 5 to 10 year, success rate, for embolization. I would say if we picked our patients successfully and we did a good job of picking the patients for whom embolization would be the best option, I would say it would be in excess of 75% success that they're not going to need anything further. So younger the patients, having the embolization, we have the greater risk of relapsing after the procedure, because they have 10, 15 years to go before menopause hits for them, in which case their normal uterus, which already likes to grow fibroid, may grow new fibroid, and they may end up having new symptoms before menopause catches up to them. And so I think that's something that we definitely have to consider. Younger patients, and I'm talking about patients in their 30s who are interested in future fertility, future pregnancy. I'm kind of mixed about that, because I don't know that I would necessarily recommend fibroid embolization as the first-line treatment. We do have some literature now suggesting that fertility rates are very close to myomectomy rates, about 38 to 50% after the embolization. but there are risks, especially, with preterm labor, having increased risk of having miscarriages, so I don't know that this is the number one procedure I would recommend to patients in that situation.
Well, I would agree with you. I mean, this is why I think this collaborative practice is so important. What most of the literature shows, I was going to say, what most of our patients or most of the literature that we're following says that if you want a baby and have symptomatic uterine fibroids, you should find the best surgeon, the Dr. Kings, the Dr. Coes, the Dr. Valentines that are with our group to offer a myomectomy. Because of those risks that you just mentioned, including the potential risk of hemorrhage at the time of delivery. And there's more of what we call a take-home baby rate, meaning you have a baby in your arms and less risk for miscarriage, less risk for the placenta getting stuck. And so I think those of you who are listening, if you're thinking about pregnancy while we collaborate with interventional radiology, it really is for myomectomy. That is the current thinking about that. And it would be the exceptional patient or the unusual patient that we would intentionally make a referral for uterine artery embolization for the risk that Dr. Moon just outlined. So I would say that's important. And then finally, a couple of quick questions here for you, Dr. Moon. Do you think patients should just show up making an appointment with you on their own without talking with their gynecologist for this procedure? Or do you collaborate?
Well, you know what? I think, number one, collaboration has been such an important piece of a successful outcome for our patients. I think, our patients have already established relationship with their gynecologist. I think the conversation should start there. I think the patient should feel comfortable enough to ask questions, and have the gynecologist give her all the options. And if she doesn't hear all of the options, I think it's important for her to advocate for her own healthcare. Internet is a very powerful tool. Read as much as you can, ask questions. I think that's what we need to do. You need to have a conversation with a gynecologist. And if you are interested in having a conversation with an interventional radiologist, you should feel comfortable mentioning that to your gynecologist and having them give you a referral, which I think would be appropriate. Oftentimes, and Linda knows this better than anybody else, I mean, I'm reaching out to her, she's reaching out to me, I'm reaching out to Rosanne, she's reaching out to me. I mean, we have kind of an open highway of conversation about, patient management and how do you treat this? Is this a candidate? Is this patient not a candidate? So I think the best situation is collaborative. I think we need to have a conversation. If there's a particularly complex, patient, I need to know that my gynecology colleagues have my back and vice versa. Okay. And so, yes, while you are welcome to reach out to me outside of your gynecologist, I think in the ideal best situation, we all talk about it.
Right. And I would just say, I've been at the clinic forever, as have you. What I really love about the way we practice as physicians, we talk to each other. It's a very open, it's not territorial. And we actually have, for those viewers, when we have a complex case, we do what we call tumor boards or interesting meetings where a whole team is there. We can look at images. We can get Dr. Moon on the phone or a radiologist on the phone. We put together not just our own opinion, but that of multiple people in the room to come up with what we think is a great treatment option for women. Often in cancer, many of you have heard patients have what's called a tumor board, where their cancers are talked about by multiple doctors, the surgeon, the oncologist, the whole team. And so we do this at the Cleveland Clinic, and it's a very unique proposition that we offer patients, often behind the scenes, Or sometimes I will call and say, we just presented your case, we've looked over all of your imaging, and we think X, Y, or Z would be the best option. So I do think that not many places do this, and I think getting experienced physicians, both clinically and with lots of years of working together, makes us a unique organization, especially for the care of our gynecologic patients. I'm going to come back to you in a moment, Dr. Moon, but I do want to go to our robust patient advocates, Ms. Venable and Ms. Gray. And I'm going to have you each tell us a little bit about what you do. I know you both. You often host webinars and podcasts for women suffering with fibroids. Let me just ask each of you, I'll ask you, Soteria, first. Tell us the typical story that you might hear. And then for Ms. Gray, I'll ask you a little bit about how you provide advice with your organization, and each of you to tell us a little bit about your organization also. Soteria, I'll have you go first.
Dr. Bradley, thank you for having me today. It's such an honor. I've watched Celebrate Sisterhood for quite some time, and it's just a wonderful annual program that you've developed. So I applaud you for that, and you're one of my absolute favorite physicians in the gynecologic space. And I just really appreciate the conversations that I've heard to date on this program. I really, the Fibroid Foundation is a fibroid patient-founded organization where we support the fibroid and menstrual health community. Our goal is to educate patients on fibroid treatment options, to provide peer-to-peer support across many platforms, to bring them in touch with wonderful treatment providers like you and the physicians who are here today. We also promote legislation in the fibroid research space. We advocate and design research studies so that we can assure that the patient is thought of first in the research study, and they're not a victim of the study, but a contributor to the study. We advocate for patient and physician collaboration, which is so incredibly important. And lastly, we consult in the medical device space because we found that, and we often say that a patient is an expert in her body. And when you have an opportunity to bring forward the patient voice along with the physician voice, it just makes it an optimal solution. We are global, and we have a community of 29,000, and we're based in the DC area. This is excellent, and I've worked with you really over the last few years on many research projects and registries, so I'm so glad that we could all get together here today. And I'm also going to ask Ms. Gray, similarly, tell us a little bit about your foundation. And I think when I see you, I think you've got a white dress on today or something white, correct? So tell me about the color in terms of how you chose it, your organization, and what you guys are doing.
The White Dress Project is a nonprofit organization. We're dedicated to raising awareness of uterine fibroids. White is very important to us because it speaks to the hope that we have around fibroid research and education. After my first myomectomy in 2013, I decided that I wanted to do something about the awareness of uterine fibroids. I felt like we were talking about it in our silos, but not talking about it on a national and global level. White is very important to me personally because after my first surgery, I realized that I didn't have any white in my closet. And I understand that to some that may not be a big deal. You don't have white, wear black. I understand that. But for me, I had sacrificed a piece of clothing that I like. And when I thought about how many accommodations I had made in my life for these quote unquote benign tumors, it just resonated with me that this was an area that I did not choose to participate in, or, when I think of white clothing parties or any social activities, it just resonated with me that it was something that I felt like I could not do. So obviously, I think Dr. Koh said it earlier, that not every woman who has fibroids has these symptoms of heavy menstrual bleeding, but there are so many of us who do, that the color white and white clothing resonates with us so much because you don't feel comfortable wearing it. So that's where the idea of the White Dress Project comes from. It's a symbol of hope, and it's a symbol that we will find a cure and dedicate more funding and research to finding out what is behind this condition that plagues so many of us.
Excellent. And since you're on screen right now, let me stick with you for just another moment to tell us about the research. What kind of research dollars are you looking for? What do we need?
So we need a lot. I'm sure Soteria would agree with me that the funding that has come from our governmental agencies has just not been adequate when it comes on to uterine fibroids. And we are advocating for that. One of the things that the bill suggests that Soteria and I worked on with Congresswoman Yvette Clarke's office is that $30 million would go towards CDC and the NIH and other governmental agencies that would aid in uterine fibroid research. And that would be $30 million for the next 5 years, or for each year. So 150 million total. So that type of number is significant in this space because we haven't had significant dollars dedicated to this research project. So I think that, the things that we're doing now, the things that both of our organizations are doing to engage with NICHD, NIH, Office of Women's Health, what we're doing with our congressional partners, I think all of that speaks volumes to how we're changing the narrative around what is done with uterine fibroids and the research that congressional members are understanding that needs to be had. So we definitely are making our mark and making our way there, but we're definitely not there yet in terms of funding and the research that needs to be done.
Excellent.
But the bill, the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act, is definitely a start. I'm proud to say that both of our organizations had a hand in that.
And Stephanie Tubbs Jones is from Cleveland, was a notable, legendary figure in our community. So I think this really honors her foresight from even decades ago about the need for this. I just
Absolutely.
have 2 more questions for each of you. How do patients talk to their physicians? We've got an illustrious group of doctors here on our panel. What are the sort of do's and don'ts? I'll start with you, Soteria, in terms of the critical conversations that patients should have with their healthcare provider. How do they do it? How do they get started? What's in their toolbox?
Well, we try to help them with the toolbox. I think there's a lot of vulnerability when a patient seeks out a physician and has an appointment. And I think that there's also a history of following what a physician says and not really having that power to really raise your voice and advocate for yourself. And so overcoming those norms of the past can be a little challenging at times. And I was so pleased to hear about your collaborative efforts at Cleveland Clinic and how you interface with patients, because that is not the norm, sadly. And I really wish that it were. I really find that we're often trying to support patients, help them to find a roadmap, help them to take a list of questions with them and know possibly what to expect in terms of questions from their healthcare provider to be able to respond to. But I think there's so much work to be done. We really focus on trying to make sure that the patient feels at ease. I think that requires that we speak with physicians that aren't as compassionate and self-aware as the Cleveland Clinic team, which is a great concern of mine, of what I've seen in terms of advocacy. So I think the bedside manner is as critical as the care that is provided. And so finding that happy medium and encouraging patients to, I think this program is fantastic because people will see this and say, oh, that's how I'm supposed to, receive information from a healthcare provider, and I haven't been receiving that to date. So let me find someone who's going to show that level of compassion with me and provide that level of information.
So Ms. Gray, I'd like to know a little bit more about the fibroid bill. What is it? How did you get involved with it? And what do we need to most know about it?
We are so proud of the Stephanie Tubbs Jones Uterine Fibroid and Research and Education Act that was introduced by Congresswoman Yvette Clarke in March of this year. I'm really excited about that bill because it would allot $30 million for the next 5 years, which would equal $150 million for uterine fibroid research and education and overall awareness. So really, really proud to be a part of that, along with Soteria, with the Fibroid Foundation and other patient advocacy groups, really speaking up and speaking out to our members of Congress, stressing how important this legislation is. We were so fortunate to have Congresswoman Yvette Clarke, who has spoken about her fibroid journey publicly, and really, I think, just took on and made sure that this was introduced and in a forceful way and an impactful way. And I think that every member of Congress needs to sign on, in my opinion. And I think that constituents across the country can sign on as well and write letters and ensure that this gets passed. Because even if fibroids doesn't affect you directly, you know a coworker, you know a distant cousin, a sister. There are so many people who are managing life with uterine fibroids that it really impacts us all and really speaks to how this is a global issue. So really proud to be a part of this legislation and really working hard to ensure that it is passed.
Excellent. Tell me what those numbers mean to you. Is there another way to frame, it seems like $150 million or $30 million a year. Can you help me understand that a little bit? How do you look at those?
Absolutely. I mean, at first glance, that may seem like a big number, but when you consider that 26 million women in the United States suffer from uterine fibroids, that's really just a little over $1 a year for each woman affected by this health concern. And I always think of it as the research should really match the size of the community. And to date, that unfortunately has not happened in the fibroids community. And we need that to happen for us to make some significant forward movement in terms of treatment options. I think we've uncovered a lot to date, but there's a whole vast amount that we still don't know about this health concern. And so I think that it's important that we continue to press forward. And I echo Tanika's comments that, lots of even men that I speak with, they'll mention that they met someone in the fibroid space and they'll find out for the first time that their mother had a hysterectomy due to fibroids, or their aunt or their sister. And so you definitely know someone affected. It's a huge issue, and we really need everyone's support in the community to be able to make an impact, a positive impact.
If you could tell me a little bit of the stories you hear from women who are looking for doctors in hospitals. What are the stories? Tell us a patient story about fibroids, her symptoms, and I think you've shared openly your own struggle, your own personal life experience with fibroids. But just tell us what you're hearing. What do people write in about? I want to personalize it because we've talked about treatments and myomectomies and hysterectomies and uterine artery embolization, but what's the patient's story? Why would she want to be seen by a physician?
I've found that the stories that I hear mimic my own experience quite a lot, and there are some common themes. Some of the common themes that we hear are that patients feel like they're alone. I definitely felt like I was alone when I was suffering with heavy menstrual bleeding. I didn't have any very close friends who were suffering like I was, and I just felt like I was on an island until I started to learn about fibroids and the statistics. I think the unspoken theme is the emotional toll that uterine fibroids takes on yourself, on your relationships, on your work experience, on day-to-day quality of life. And I'm so happy to see that conversation being addressed more openly, because I think it's very critical. Another theme that we see is that patients have never heard the word fibroid when they're diagnosed. And I know that sometimes we can become accustomed in our own spaces and maybe within our community medically of having that conversation and knowing what these terms mean. But all of these terms are foreign most of the time to most patients. And so those are just three of the themes that come to mind. First off, there are many more, like the family dynamics, and I'm sure that Tanika can expand on some, because there are many common themes that we see raised that we try to address with that peer-to-peer support and with just really embracing patients where they are through our chapters on the ground.
What I actually want to just say for just a brief moment, we've talked about surgery and we've talked about the uterine artery embolization. I do want to talk a little bit about medical therapy, because it also is an important arm in our toolbox for medical treatments for women. And there are several medicines I think patients should know about, because we're really treating symptoms. It's usually bleeding, pressure, pain, heaviness. Sometimes a normal uterus is the size of a lemon, but it can grow to be the size of literally a turkey or a basketball. So depending on the size, the number, the location of the fibroids, we have different medications to treat these various symptoms. And I do think it's important for our viewers to know that it's not always a procedure, but you should know that sometimes, and I'm just going to list categories without names of products, that there's medications like hormonal therapy, birth control rings. Sometimes we use medicated progesterone IUDs. Sometimes we use medicine that's only for 5 days out of a cycle. It's called an antifibrinolytic that helps to decrease the quantity of bleeding. And in May of last year and just this year, we now have oral therapy, medicine that you can take by mouth either twice a day or once a day, and it can be now used for up to 2 years. We call it a GnRH antagonist that can be taken by mouth, that allows women to almost stop bleeding. If you're not bleeding, your anemia will improve, and the studies have shown that. In addition, some of the drugs have been shown to decrease the size of the uterus, so some of the symptoms of pressure, looking pregnant, heaviness, weightedness, backache, leg pain may be treated by medical therapy. So again, it's hard to say when you're watching today which one of us would treat you with what. I think your doctor has to really listen to your story, look at your imaging. Often we start with ultrasound, but your physician may also order an MRI, and just be able to know that when you go into your physician's office, you need to ask about new treatments. Hey doc, what did the FDA just come up with this year and May of last year? They should be able to talk with you about medical therapies we call GnRH antagonists. And there's also an injection that's been around for probably 15 or 20 years that's also given on a monthly basis. That's not a birth control shot, so to speak, that can help with many of the symptoms. So I'm excited, just as someone that's been involved with some of this research and writing for medical management, that the right doctor, the right team will find out what's going to work for you, and make sure that when you're getting an opinion, you've looked at not just the surgical things and the procedural things, but are there some medicines that can tide you over or make you better also? And again, that's something important to know. And I'll go back to Ms. Gray at this time to ask another big question in terms of what do you think are the biggest research dollars, or how we should, let me just rephrase this, how should the research dollars be spent if we're able to get this grant or to get this congressional money that you're advocating us to have?
I think it's so important for us to think about how we can have the patient voice and the patient perspective involved at every point. So it's fundamental for us to get this funding. However, we have to have multiple conversations around how is this money going to really support patients and clinicians and our overall healthcare system and how we treat women with reproductive health issues. And I think it's equally important to not only have the patient perspective, but ensure that we have clinicians' perspective as well, to ensure that they can speak about the limitations they have as clinicians. So the point is that it's really what this entire programming today is about, celebrating sisterhood and celebrating collaboration. Because until all of our voices come to the table, patients with a very unique perspective of what we need, how we need our doctors to interact with us, how we need to be heard, and oftentimes we feel dismissed. So how can we eliminate those things along with aiding in the limitations that doctors feel like they have with time and seeing multiple patients and just the limitations they have. So the work that the money would go towards for the CDC and NIH and ICHD and other agencies, I think would be very helpful in the beginning to get those perspectives out. Obviously, then we would, I've heard multiple suggestions about forming an agency within our current agencies that specifically deals with uterine fibroids and endometriosis and PCOS. So I think there's a lot of work to be done, but what I want to stress is that this money can definitely be used to bring the patient voice in very, very early. Not at the end when, the suggestion may come from someone that, oh, by the way, we need a patient voice, but it's imperative that we have the patient voice from the very beginning. So proud to be a part of this legislation and really confident that we will get it passed, but it's going to take the work of all of us. I was saying earlier that all of us has a member of Congress that we can reach out to and share why legislation like this is so important.
And I love what all of our panelists have shared with us today. Some of my personal conclusions are, don't be ashamed to talk about your symptoms. Know your body. Keep a journal. Don't ignore symptoms. Have critical conversations with your healthcare provider. Make sure your physician examines you. Know your options. Get a second or a third opinion. Many offices now offer virtual visits to first discuss your symptoms. And there is relief, and there is hope for your symptoms. Support the fibroid bill, and send a note to your congressman or congresswoman about supporting the fibroid bill for more research. We have learned so much and have many new tools in our toolbox to help us navigate discussions with our healthcare provider regarding endometriosis and fibroids. I'd like to thank all of our guests for their time and their expertise. Thank you for your patient-centric care and for your advocacy that will help bring us closer to more research dollars for fibroid and endometriosis and patient awareness. Thank you. And thank you to all of our viewers for joining us for this program. A copy of this session, along with all of our archived events, will be available on our website, clevelandclinic.org/celebrate sisterhood. Just a reminder, this event was pre-recorded. If you have any questions about the information shared today, please email. Our next event this year will be on October 9th. It will be our first ever full-day virtual health summit filled with education and entertainment. You won't want to miss it. To learn more, visit clevelandclinic.org/celebrate sisterhood. Remember, we are here to help you. If you need to make an appointment with a Cleveland Clinic provider, please call 866-320-4573 or visit clevelandclinic.org/appointments. Please stay healthy and stay safe.